My name is Dr. Shamim Siddiqui, and I'm going to take over next session. May I invite our next session panelist to please come on the stage so that we can proceed. Dr. Salman Waheed, Dr. Imran Iftikhar, Dr. Gulzar, Dr. Imtiaz, Dr. Javed Ashraf, Dr. Sumaira Naseem, please come on the stage. Dr. M. Hassan. Okay, may I request Dr. Kashif Sheikh, please come on the stage. Dr. Javed Ansari, please come on the stage. So Dr. Gulzar is not here. My first presenter is not here, so I'm going to start with the second one. So you people have at least few minutes to continue. The presenter is here. Let me ask Mr. Waseem from Lahore. So he's going to present abnormal high origin CTO, which is always a challenging case. Please welcome Dr. Waseem. Thank you.
Assalamu alaikum. I'm Dr. Waseem, postgraduate resident at Jinnah Hospital, Lahore. Today, I'm going to present an interesting topic of abnormal high origin CTO RCA is always a challenge. So, a 45-year-old male patient with history of unstable angina presented with normal renal functions. He underwent coronary angiogram, and this is the angiographic pictures showing LCX was blocked proximally. LAD had moderate proximal stenosis. RCA could be partially engaged even with repeated attempts and using multiple available diagnostic catheters. Left injection showed retrograde filling of distal RCA via collateral from left system. So we decided to proceed for the angioplasty of RCA. We tried to engage the RCA ostium with multi-purpose guiding catheter, but couldn't succeed. RCA couldn't be engaged even with switch to left radial access. Ultimately, AL1 guide engaged the vessel properly, and pilot 200 wire was taken with support of supercross micro catheter and passed to RCA. Tip injection through MC catheter confirmed that wire was in the true lumen of RCA, and contralateral injection confirmed that distal wire was in a small branch. So wire exchange to BM wire over multi-purpose catheter and redirected to distal PDA. After preparing the vessel with semi-compliant balloon of size 2 into 12 mm, we placed a Promise Premier stent of size 3 into 24 mm and deployed the stent at 14 ATM. We took another stent of size 3 into 38 mm and placed distal RCA and deployed this at 14 ATM. So these are the final results after post dilation with 3.5 into 12 mm NC balloon. After 2 weeks, we staged plasty of LCX. So LCX was totally occluded. A Promise Premier stent of size 2.75 into 12 mm was placed and deployed at 14 ATM. So these are the final results after post-dilation. So key learning point in this case was unusual coronary origins require unusual guide choices. Multi-catheter tips injection and contralateral injections are excellent choices for distal wire position confirmation. Thank you.
Thank you. That's an excellent case. I think, CTO is always challenging, and if you have the origin of RCA, which is actually not normal, so that's in these cases C2 is always very difficult to approach. So if you have any question from the audience, I would like to ask question from audience and then I will direct it. Dr. Faisal, you want to ask? Okay, please give.
You said that you used multi-purpose guide initially. Do you think that was the right choice, to begin with? And the other thing is, you can also, for this kind of lesion, you can also use JL 3.5, Judkin left, and you deep throat it, it rotates, and then that sometimes is also a very good choice for a guiding catheter. But the AL, was it AL1 that you used or AL2?
I am Dr. Ahmed Mukeet. I'm assistant professor of cardiology. I was supervising this case with Waseem. And during angiography, we showed that we used multiple catheters, including the mentioned catheter JR 3.5, which was used, and this was the best reach that it could make, including multipurpose catheter, which was not used during diagnostic shots, but it was used during the angioplasty when we tried. But it also could not engage. The last and the best one that engaged was AL1, Amplart's left, and that was one. And it engaged properly, and then we could finish the case.
I have questions, sir. Do you ever think about your really looking at the circumflex disease, circumflex lesion, the total occlusion? Do you think the way the dye was hanging over there, it looked, then the subsequent on angioplasty, you went very easily through the lesion. Do you think that could be the acute lesion rather than the RCA?
Yes, very pertinent question. And when we did this circumflex as a stage procedure, circumflex was already almost opened. It was not CTO. Yes, it was clotty, and I was hanging it. Very pertinent observation.
Well, okay. I would have, the reason I asked this question, and because to me it looked like a kind of more acute lesion, the way the dye was hanging there, and then subsequently the way your wire went through it easily, and you did it very easily compared to the right one. I might have gone through the circumflex at the beginning rather than 2 weeks later. That would be my kind of thinking on that. Yes, subsequent. It was proved. Yes, subsequent was proved.
My question is that after opening the RCA, the CTO, what was the patient course, whether he remain asymptomatic or?
Madam, patient is asymptomatic, he is compliant to medicine, and he is in regular follow-up, and he is now asymptomatic and doing well.
Yes, yes, please.
Okay, now 2 to 3 points for beginners. First of all, when you don't see the RCA in the right cusp, don't do the injection repeatedly in the right cusp. You just give in the all cusp. Then, especially for this, you should give injection at high origin. In front of the left vein origin is type C origin. So again, sir asked the question, do you think multi-purpose is a good choice? I will say for this origin, you should start with multi-purpose because it's just cup-shaped and multi-purpose will easily engage. Though they were failed, but I would also will take the multi-purpose. My first choice will also be the multi-purpose. And when it will engage, it will give you a good support. You will deeply engage the multi-purpose and will do the PCI. And second point, at least you should try probe the circ. Maybe you will at that time successful to open the circ and you lost the time of the myocardial perfusion of the circumflex, and when you open the circumflex at that time maybe already myocardium is dead.
Thank you. If there is no more comments, so I would like to proceed for the next case. Dr. Khurshid, you want to? Okay.
Yeah.
Please.
Actually, these guides behave differently when you go radially versus when you go femoral. Actually, sometimes it helps Instead of going radially, you go femoral, and the same MP guide would sit very well. And I totally agree that MP would have been my first choice in here, because it's an inferiorly directed RCA, so MP would have been a good choice.
Thank you, sir.
Excellent case, actually.
Thank you, Dr. Waseem.